Hello, everyone, and welcome to the second webinar promoted by the HUMI Group. My name is Flavio Foliato, and I'll be moderating today's webinar. The HUMI Group is a consortium of researchers from 7 different countries, joined by their common interest in topics related to lean healthcare, healthcare operations management, and analytics. You can find a list of our research outputs, as well as short bios of the group members, on our website at hilmigroup.org. The title of today's presentation is Resilient Healthcare During COVID-19. We have 2 speakers, Dr. Tarcísio Saurin and Dr. Mariana Falseta. Our first speaker, Dr. Saurin, is an associate professor in the Industrial Engineering Department at the Federal University of Rio Grande do Sul in southern Brazil. He holds a master's and a PhD in industrial engineering. He is also a member of the HUMI Group and internationally renowned for his works on resilience engineering, ergonomics, and lean production. Our second speaker is Dr. Mariana Falseta. She works as a physician at the Clinics Hospital of the Federal University of Rio Grande do Sul in the Occupational Medicine Service, and she is also a member of the hospital's Internal Regulation Center. She holds a bachelor's degree in medicine and is finishing her PhD in endocrinology. This is how today's webinar will work. We'll start with the 2 presentations, followed by a Q&A session. Questions to the speakers should be posted on the chat anytime during or after the presentations. We'll compile the questions and read them to the speakers. On behalf of the HUMI Group, I would like to thank the presenters for accepting our invitation to speak at the seminar. And with no further delay, I now pass the word to Dr. Saurin. Good luck with your presentations.
Okay. Thanks, Flavio, for this introduction. Thanks to the organizers for this invitation. I'm very happy to be here with you. So the title of my presentation is Resilient Healthcare, a Theoretical and Practical Perspective of the State of the Art. My purpose here is to give you an introduction to resilient healthcare and also to provide some background for the next presentation. Well, the topic of resilience has been studied in healthcare for a long time, but it's usually approached from a psychological, individual perspective. On this slide, I put a traditional definition of resilience from this psychological perspective. Let's have a look at this definition. Resilience is the ability of the human subject to thrive despite adversity and stressors like poverty, psychopathology, and trauma. So, according to this view, resilience lies on individual abilities, skills, and personality traits. From the perspective of resilient healthcare, which is a discipline based on human factors and engineering, the definition of resilience changes. It's a systems-oriented definition. On this slide, I put what's probably the most well-known resilient healthcare definition. It's the ability of the healthcare system. This system can be, for example, a clinic, a ward, a hospital, or even the public healthcare system, the public healthcare network of a city, region, or country, to adjust its functioning prior to, during, or following events, and thereby sustain required operations under both expected and unexpected conditions. So This definition conveys that resilient healthcare has both a proactive dimension, acting prior to events, and also a reactive dimension, following disturbances and other undesired events. And another important point in this definition is that resilient healthcare is concerned also with unexpected conditions, which go beyond standardized operating procedures, which go beyond everyday work. Eric Holnagel, which is one of the leading academics in this field, he also proposes four abilities of resilient systems. These abilities are responding, monitoring, learning, and anticipating. Resilient healthcare is now a maturing academic discipline. There is a growing number of practitioners and researchers interested in this topic. So we can talk about resilient healthcare knowledge hubs. I would recommend for you, especially the Resilient Healthcare Network, which is a growing community of researchers and practitioners. This community meets every year in a meeting. Next year, the meeting will be in Sweden. You have here the website of the meeting. You have here also the website of the Resilient Healthcare Network. There is also a book series that compiles the main research outputs produced so far by this community. And there is also a recent special issue in the Safety Science Journal focused on resilient healthcare. So why is resilient healthcare necessary and useful? Why are people interested in this topic? Firstly, because resilient healthcare has provided insight into patient safety and performance in healthcare services in general. This is a very important topic because the literature indicates that about 1 in 10 patients will have an adverse event after being admitted to a hospital. Furthermore, there are some studies pointing out that 40% of care provided to patients is not in line with clinical evidence. There is so a difficulty in translating evidence-based medicine to the everyday practice of clinicians. And furthermore, there is a need for balancing economic pressures and safety in health services. These are all practical problems of health services that are problems of interest to the resilient healthcare discipline. And furthermore, resilient healthcare pays attention, recognizes the complexity of health services. So this approach, this proposal of resilient healthcare is not limited to mechanistic approach, to just following plans, to just controlling top-down the healthcare services. It recognizes the diversity of elements, the scarcity of resources, all those things that make it impossible to follow plans all the time. Well, where resilient healthcare has been applied so far? There is a common framework for investigating resilient healthcare, which divides the healthcare system according to the micro, meso, and macro levels. At the micro level, resilient healthcare is concerned with clinical work at the front line. For example, how clinicians perform in emergency departments, surgical units, primary care, and so on. This micro level so far has been the main focus of the resilient healthcare community. At the meso level, there is a concern with the whole organizations, for example, the whole hospital, the executive boards, and the interactions between hospital departments. And at the macro level, we go to the regional and national healthcare system. We are concerned with the public health policies and even with regulations. It may appear at a cursory review, it may be contradictory to talk about regulations and resilience, but there has been some discussions in several countries regarding how regulations can support resilient performance. Well, and the theoretical assumption is that the same resilient properties, they play out similarly across these three levels. In terms of complexity science, there is a concept here called fractality. This picture on the right-hand side of this slide is the picture of fractals. Fractals refer to the same properties across several dimensions, across several scales of a system. So what happens at the micro level influences the other levels and the other way around. In more practical terms, there have been some tools and models developed for investigating resilient healthcare. One of the most well-known tools is called the Functional Resonance Analysis Method, the FRAM. This method has been proposed by Eric Holnagel. You have here the book with the FRAM proposal. And the FRAM is a very interesting tool to understand work as done in healthcare services. By work as done, I mean how work is actually performed, which is usually different from work as imagined by procedures and policies and rules. Another tool which has gained traction in the resilient healthcare community is the resilience assessment grid. This is essentially a questionnaire which allows us to identify, to understand our performance according to the four potentials of resilient systems that I mentioned on a previous slide. Responding, learning, monitoring, and anticipating. There are several adaptations of this tool for different health services. For example, there are adaptations tailored to emergency departments, to intensive care units, and so on. And there are also other less popular, less well-known tools. For example, after action reviews. Some hospitals have applied this approach, especially in Europe. It's basically a short meeting at the end of the working day when people reflect about, especially people reflect about what went right, about what went well during their working day. In addition to the traditional reflection about what went wrong. There are also some people, for example, us in Brazil, myself and Flavio and others, working with social network analysis as an approach for investigating resilient healthcare. Some people working with agent-based modeling, system dynamics. And basically, these tools listed on this slide are the most well known so far. Just to give you a more practical idea of the resilient healthcare studies, I would say that most of the studies have been concerned with the description of everyday clinical work. The intention here is to learn from ordinary adjustments made by professionals. And as I mentioned, these studies of everyday clinical work, they shed light on the gap between work as imagined and work as done. And these studies help us to make sense of this gap. They There have been some proposals on taxonomies of the gap, on how to quantify the gap, and on how to investigate the influence of the gap on patient outcomes. Another common stream of resilient healthcare studies refers to retrospective analysis of disturbances. By disturbances here, I mean usually natural disasters or man-made disasters that demanded a lot of resilience from health services. The next presentation actually is an example of this, because the next presentation will describe how health services have dealt with the pandemic. And on this slide, I list also an example on an investigation of how hospitals in Sweden coped with blizzards. There is also another example on how the health services in New Zealand dealt with an earthquake, and several other similar examples. And in all of these studies, the focus is usually on learning from what went right. I would like to emphasize at this point, because this is a distinctive characteristic of resilient healthcare. The assumption here is that the same variabilities, the same learning opportunities exist both when things go well and when things go wrong. So we don't need to wait for failure. We don't need to wait for adverse events in order to learn useful things. There is also a term used in this community, a concept used in this community, which is safety two. Safety two is this safety management, this systems management approach that also pay attention to things that go well. And it's in contrast with safety one. Safety one is only reactive and only concerned with things that go wrong. Well, based on the resilient healthcare research outcomes so far, we can see that there is a way ahead for researchers and for practitioners. And I listed here some opportunities for further research. First of all, I'd like to emphasize the need for moving from description to prescription. Most of the studies, as I said before, are descriptions of resilient performance. So there is a big and an interesting open question on how to design and evaluate an intervention that supports resilient healthcare. I would say that this type of intervention should account for the 4 resilience potentials: monitoring, learning, responding, and anticipating. These interventions should also account for unintended consequences. because under in light of complexity science, there are no real and definitive solutions. As systems are dynamic, solutions are always are prone to unintended consequence. And I would also make a provocation here and talk about interventions that not only involve adding new practices, new elements to healthcare services. Sometimes an effective intervention can involve the removal of existing practices. There is a concept that Sidney Dekker, which is listed here, calls decluttering. Decluttering means the removal of unnecessary bureaucracy, unnecessary audits, indicators, and so on. This type of intervention can also be useful for supporting resilient performance. There is also an opportunity for integration between resilient healthcare and other management approaches. For example, lean healthcare and healthcare 4.0. These management approaches, they will probably keep being used, likely more and more, for several reasons. And I think that resilient healthcare, this complexity perspective, can play a prophylactic role. We can probably design a better lean healthcare, better healthcare 4.0 implementations if we take into account from the outset the limitations, the implications of the complexity of health services. We will not be so mechanistic. We will not take for granted that things will work because people will follow procedures all the time. We will be more humble to a certain extent by using the lenses of resilient healthcare. There are also opportunities for exploring the multi-level links across the macro, meso, and micro levels for understanding adaptations across levels and unintended consequences. There is also an opportunity and a need for developing resilient healthcare competencies in the workforce. And here, there have been also discussions about the revision of the curriculums, of the patient safety curriculums. And lastly, there are also opportunities for investigating the implications of trends such as home care, genomics, and new funding models on the resilience of health services. So in short, I think that resilient healthcare has the potential to be a comprehensive framework for the management of health services. It's not only about safety, it's about performance in general, and there are plenty of practical and theoretical opportunities. So thank you very much. I put here some references on my last slide, and I think I'm on time.
Okay, Tarcísio, thanks a lot for your presentation. I will now pass the word to Dr. Mariana. Good luck with your presentation, Mariana.
Thank you. I'd like to thank the invitation to speaking here today, and thank you, Professor Saurin, for this introduction. And I was invited to talk about an article that my colleagues, Dr. Hadus and Dr. Dora, we published in September of this year on how a Brazilian hospital developed a COVID-19 ward system to mitigate limited ICU availability. And although we wrote and published it, it certainly was a work of many, many people. My name is Mariana Rangel Ribeiro Falseta, and I work in Hospital de Clínicas de Porto Alegre in internal medicine department. Here to put you in a context, we had this big challenge. We had the biggest hospital in South Brazil, which is a public tertiary care teaching hospital. And in the beginning of 2020, we were just coming from a 5-year construction for a building that would double our size. And a few weeks later, we just received the first notice of COVID in Brazil. So very early in the pandemic, the federal government appointed our hospital as a regional reference hospital for treatment of critically ill patients with COVID-19. And with that, we went from zero ICU beds dedicated to COVID to 84, and then to 135 ICU dedicated beds. But this wasn't enough as the pandemic got worse. So as the pandemic got worse, the demand for ICU beds and ward beds increased abruptly. And we had no further options to increase ICU environment. We had already 921 beds from this 642 ward beds and 135 ICU beds dedicated only to COVID-19. And other beds spreading through other areas of our hospital as general ICU beds, pediatrics bed, and emergency room beds. So the big challenge was that we had critically ill patients in common ward beds. And our goal was to meet the demands of this unique patient profile in the wards and to provide them adequate support. So we had to took off a sequential adaptations to care for these patients and to attend their specific demands. Here are some of the actions we had to launch. They are the main ones, but certainly not the only ones. So we had to increase the medical teams, increase of beds, to install 24/7 continuity of care, bed management team dedicated to COVID, specialized ventilatory support team, and increase in physiotherapy team. I'm going to talk a little deeper on each one of these measures that we took off. So increase of medical teams. In the very beginning, we had only one single team caring for the patients in the wards, COVID patients in the ward. In a usual configuration, one preceptor and 2 to 3 residents. But then more teams were created, and we have to relocate a professional from other areas in our COVID ward, And as the pandemic got even worse, we had to hire physicians by temporary contracts to even to expand the number of these medical teams. We have to obviously to do increase of beds in the ward. And I show you this picture that I think is quite illustrative of how elastic our system was to do that. So here in green, we have the confirmed COVID cases. In bluish green, we have the suspect cases, and this orange line, the number of beds. So we can see here in the beginning of the pandemics, we had the first beds we opened were at the number of 18, and then as soon as 2 weeks we increased to 32, and then as steps in the stairs we had to open more and more, reaching the first peak of the pandemic in our country in July and August of last year, 2020. And we kept these beds opened for these 2 months. And then with the cooling down of the numbers, we would be able to close some beds back step by step too. And during the spring and summer months, we had relatively stability of the cases in our hospital until the end of February, when we had for sure the most critical period of the pandemics in our region, and I think in whole Brazil. And we can see here that this line doesn't go step by step, but goes just way up. And this lasts for a little bit longer than a month, and then we would be able to close some beds as well. Then we had a little more months of stability in May, June, and in July we could again close some more beds, and we have this stability, low occupancy until today. Of course, to care for these patients, the dynamics of putting new medical teams was proportional to the opening of the beds, and as well as the close. When we closed, we could relocate these professionals to their original areas. I think this is the most illustrative figure of the pandemic dynamics in our hospital. There was this moments of care transition that we had to install to guarantee this 24/7 continuity of care. So one of these moments was the morning report. There was a brief moment when physicians in the medical night shift report to the rotating teams about the patients who require attention during the night. And the COVID huddle, it's a moment in the end of the day where rotating teams report to the night shifts the patients with increased risk of clinical deterioration. We install a bed management team dedicated to COVID, actually a representative of the bed management committee that we have in our hospital from many years before, was relocated to work only in the beds, in COVID ward beds. And together with a social service agent, they went through the teams every day to assess the possibility of external transfer. What that means is that in our city, we have these hospitals that have intermediate complexity, and sometimes we could transfer patients that were not too critical, but not yet ready to be discharged home. They could be transferred to these backup hospitals. So this team would assess the possibility for external transfers. We installed an specialized non-invasive ventilatory support team composed by 2 pneumologists and 1 physiotherapists, and they would help in evaluation of patients in need of ventilatory support, definition of the parameters, adjustment, and withdrawal when that was possible to do. Increase in physiotherapy team, so physiotherapists were relocated to COVID ward from other areas of our hospital, but that was not enough, so we had to hire more physiotherapists. And then this hiring allowed the extension of the coverage period from 14 hours to 24 hours a day. Here is another figure that showed the ward assistant coverage. So we had here the nursing team, 24 hours a day, the medical teams divided in rotating teams during the day and the night shift during the night, obviously, and the coverage of physiotherapists 24 hours a day. And here I point out these moments of care transitioning and sharing decisions. Here, the morning report, 8 o'clock, the non-invasive ventilatory support team round together with the routine teams, the visit of bed management team and social service agent, and the COVID ward huddle just before the night shift. Another point that is important to highlight was the training that all the teams working in COVID areas received, especially in the ward, because these patients, they were in closed bedrooms. Anytime anyone had to go there, it was important to check if their mask was right in place, if the machine was working. So we have to train all these people, nurses, residents, physicians that were not specialized in that, and physiotherapists to know how to identify any problems if there were any. So we had this training on a regular basis. In the most critical months of the pandemics, they happen once a week, and and staff could do as many times that they want to, because for us was really important to have trained people working there. Equipment, as an usual ward, we didn't have any at the beginning. So in the first months, we could mobilize 18 non-invasive ventilatory machines from other areas of our hospital, especially from the pediatrics areas. And then they were not enough, so we earned by donation more 12 non-invasive machines, ventilatory machines, and then the hospital rent more 4 high-flow nasal cannulas only to the wards. Of course, we're not talking here on equipment to the ICU. Of course, they have many more there, but this was the equipment dedicated only to the ward. Our main hurdles, I think I'm gonna start from bottom to the top. I think the limited human resources was the biggest challenge we had. We had to overcome that with alternative forms of contracting, like temporary jobs, but that clearly wasn't enough. Until today, many professionals that work on COVID areas have still extra hours on their banks, because we had to have more people on shifts because of the profile of the patients, and we had to deal with our own staff being on license because of COVID infections. So the extra hours, it's almost everyone has extra hours from that time until today. Another hurdle that we could highlight was financial limitation to implement monitoring and equipment. So we tried to overcome that with mobilization of equipment from other areas and donations, but we had this monitoring problem as a very important one. As I said, the patients were in closed doors, and we have to go in a lot of times a day to check on the most critical patients, because we couldn't see or monitoring them by distance. And another hurdle was the qualification of professionals in a short period of time, I'm sorry. But I think of these three ones, this was the most the easiest to overcome with. So lecture and hand-on workshops on ventilatory support on a regular basis, that was one of the actions that took place, and I think we achieved the the goal with this action. A lot of teams were involved internal medicine residents, internist staff, clinical physicians, nurses, physiotherapists, pneumologists, social service agents, the bed management committee, nutrition and psychology professionals, and obviously the hospital medical board that was always there for whatever we need. Here's some dates, some metrics, some data on metrics from March to 2020 to August 2021. We attended 3,400 patients in our ward. Of these patients, 2,500 were confirmed cases. And from these confirmed cases, about half of them came from the emergency department, 1/3 from the ICU, and 21% from the non-COVID wards. From these confirmed cases, half of them were men. The mean age was 56 years old. The length of stay in the COVID wards was 5 days, but in the hospital was 10.5 days. And that's because they could spend some days in the emergency department or in the ICU before coming to wards or after. And patients could be discharged home, what happened in 40% of the cases, transferred to those backup hospitals that I told you about 3%, transferred to ICU, 21%, and transferred to non-COVID wards, about 30%. The mortality in our ward was 158 patients, about 6%. And when considering mortality in patients who stayed in the ward but then went to ICU, the number obviously goes up to 548 patients, accounting for 22% of the total. Overall mortality in our hospital, accounting for ICU, emergency room, and ward, was 23%. Where to start? That was one of the questions that the journal asked us when we sent the article to publish. And we had to think about it, but we identification of the problem, fast and coordinate response from leaders, both administrative and care delivery leaders, involve medical teams, nurses, physiotherapists to care for patients with advanced needs, alignment and communication with other units. As I said, we had to mobilize people and equipments from everywhere in our hospital, and it was a very nice thing to see how people volunteer to participate and volunteer to work there. That was certainly a very nice message that we received from the hospital community, and build a trust environment between everything and everyone in the hospital who were working on it. And we think this is the key points to face the pandemics and through these last 2 years that we have come from. So that's what I had to present to you today, and I am available for any questions you may have. Thank you.
Thanks a lot for your presentation, Dr. Falseta. We actually have several questions here for both speakers. So since there are numerous questions, I will ask for short answers so we can move on to respond more than one. The first one is to Professor Saurin. And the question is, how should we work with the people in order to induce resilience into the healthcare system? How do we handle resistance to change? And which is the role of the hospital management?
Mm-hmm. Okay, thanks for these questions. Actually, there are 2 or 3 questions here. I would say that in general, frontline staff are quite receptive to the idea of resilient healthcare, because they feel that this approach acknowledges their everyday difficulties, their everyday constraints. And another point, and there is an ethical consideration here, we should make it clear that resilient healthcare is not about leaving the burden of successful performance only on the shoulders of people. We should make it clear to everybody that resilient healthcare is about providing resources to successful performance. These resources can involve training, can involve people development, but they go beyond. They are about providing equipment, providing proper resources, and so on. And about resistance to change, this can, as I said, this can be dealt with by acknowledging the limitations of procedures, of rules, so workers will be receptive to this approach. And about hospital management, this is also quite important because hospital management usually is focused on work as imagined. They don't have a clear picture of what really goes on at the front line. So a possible important step is to reduce the gap between work as imagined and work as done, making top management quite aware of the real difficulties of the front line.
Okay, thanks for the answer, Tarcísio. I'm going to now move to Dr. Falseta so that we can have everyone answering questions. And I'll pick a question from Manish Kumar, who is also a member of the HILMI group. He thanks you for the presentation and asks which good practices hospital plan to take forward beyond COVID and embedded within the current way of working. And what is the role of digital tools in improving the resilience in the hospital, in the healthcare, actually?
Thank you for the question. I think we had a lot of things we learned from these actions that took place during the COVID. Some of them are hard to maintain after these critical moments because they require some effort from everyone. So we still have the morning report moment that we think improve the quality of the care transitioning, and the huddle. We don't have the COVID huddle anymore, but we have the night shift huddle to pass to the night shift teams the patients that we think are most critical from the day and may require evaluation during the night. But another measures are difficult to maintain because they were so focused on the critical patients in the wards, and we don't have that anymore. That it's hard to keep them ongoing. We don't have more patients in need for ICUs when ICU beds and have no ICU beds. Now, if anyone has to go, they simply goes and that's resolved. So we are trying to maintain these moments of care transitioning, but other measures some of them we had to quit because there was no more reason to keep them. I'm sorry, the second part on technology, is that
Mm-hmm.
right?
Yeah.
Okay.
The role of technology.
Well, I'm trying to think. We used a lot tables, Google Docs tables to list the patients and share this information in a rapid way, in a fast way, so that the routine teams could put there and the night shift teams could see what they have to check on each patient. But I don't think there was some thing that we could classify as high technology to do that. We didn't have any, I think. We had the monitoring, but as I said, was very scarce in our in our in our ward for the most of time, and I think was more a rough way that we did the whole thing we did.
Okay, thanks a lot, Doctor. I now have a question also from Manish to Tarcisio. He's congratulates you on the presentation, and he wants to know how FRAM helps healthcare to move towards safety 2 practices. Healthcare are using process maps, HTA, and other tools. What is the benefit of using FRAM?
Okay, thanks for this question, Manish. So I think at the initially it's important to say that FRAM also has weaknesses like any other tool. One of the difficulties of FRAM is the visual representation of the models. I didn't show during my presentation, but the models can be very confusing. They are not straightforward to understand visually. And on the other hand, I would say that the main strength of FRAM is the understanding of work as done, the understanding of everyday work. And so in this sense, I think that FRAM supports safety too, because safety too, as I said, is about modeling everyday work when things go well, but things go well not only because people follow the procedures. Things go well because people were able to fill out gaps in procedures, gaps in work system design. And so FRAM will give visibility to these situations. I think it's one more tool that we have in our arsenal of tools in health services. It has pros and cons, but I would say, again, the main point is to understand everyday work.
Okay, thanks a lot, Tarcisio. Now let's move back to Dr. Falseta. We have a couple of questions from A.B. Jose. I will read you the first one. He's thanking you for the amazing presentation, and he would like to know how was the response of the healthcare workers to the new setup, the change of job description, overload of work, dealing with new technologies of the workplace due to the pandemic.
Everybody was amazing. That's what I have to say, because everybody was so involved with everything and coping with to have to do extra hours, and we didn't have any people not wanting to be a part of it. What we got from our staff, that was everybody was available, and when one had uh, to be on license because of COVID infection, soon after someone would offer themselves to be in the place and take that shift or do their hours. So was really amazing to see how people were involved with this work, and since the beginning of the pandemics, we also see how the community uh, recognizes the work that we have done and send messages of thank you and incentivation. And I think that was a very important thing for everyone's there, because we could see that all the effort we were doing and staying away from families and having to work extra hours, that all would be recognized for the whole community. And we had a lot of times during the night shifts, uh, uh, some I don't know if it's right to say the motorboy bringing sweet candies or snacks or lunch, and from people that we don't know, just did that to help and to incentivize it. So uh, that was a really nice thing to see from the whole community. And internally, we had this same feeling to help, to cope, to be involved with all the assistance of these patients. It was a really hard time, and I think everyone did their best all the time to be there. Of course, I saw in the chat a little bit about burnout, and of course there was that, but we had this very strong and active occupational medicine service in our hospital that could be able to hold and care for our staff too. So that was very important as well.
Okay, thanks for the answer. Actually, there is a follow-up question by Avi. He wants to know if they were performing better with training. And I would like to add the question if you had time to do any specific and special training to these professionals because you were in such a hurry at that point.
Yes, as I said, we did have these trainings uh, weekly, once a week, and sometimes even more because we had this big apport of new hirings in a short period of time, and these people they had to be trained, and they were. Um, of course, as we have to hire, some people went to the most trained ones went to the ICU and the emergency department, and in the wards we had to offer them a different kind of trainings. But we have everyone trained to be able to support with quality, the minimal quality that is expected from our hospital for these patients. And for these trainings, I think a lot this group of these two pneumologists that I talked about, that were always there and always available to train all these people, and they would pick up the machines and make everyone uh, to learn how to program it and to see, to check if there was working well, they were working well, or there was any problem with it. So that was very important, and they did everything. That was really great.
Okay. Okay, we have some more questions, a few more questions, but we are running out of time. So I think we're going to close for now. And I would like, on behalf of the Hume Group, to thank again the speakers for accepting our invitation to participate in the webinar today. And to whoever is watching us, please check our website to learn some recent research outputs that are listed there and to learn a bit more about the human member groups. Once again, thanks, Dr. Falseta. Thanks, Dr. Saurin, for joining us today, and a good day to everyone.
Thank you. Bye bye.
Thank you. I thank you for the invitation and all the questions. Bye bye.